Hey, this is Dr. Chaffin from Simply Implant Institute here in Phoenix. I actually was just going to sit down today, have my little drink. I'm going to be playing golf here shortly and talk about restorative dentistry. All right, about implants. It's not just all about implants. Okay, it's funny. I noticed the students that come into our school for first 4 days, they're really pumped on implants. It's all about the implants, implants. And then after 4 days, they're caring about what's the restoration. So we're going to talk about implants and the restorative needs on full mouth cases. All right. Most people, when they get into implants, think about ones and twosies and things like that. But the world's going into full mouth reconstruction. And how do we break that down? And why is the restorative components? And how do you separate full mouth recon into different categories? So generally today, this little tip is about the different categories that I kind of like to segregate things in when you're talking about full mouth rehabilitation, not ones and twosies and things like that. So the first thing that I like to do is, your first full mouth type of reconstruction that you typically see are the full mouth cases that involve crowns. You're not missing any teeth, the bite's overclosed, and you just got to restore it. So those kind of cases are without implants, but I like to put in the category because that's part of your full mouth recon. I do see a lot commenting on this first type case, which is, so if you guys are writing this stuff down, just kind of put case type 1 is full mouth reconstruction with no implants, just crown work. Now, how do you accomplish that kind of case? Well, very simply put, you have to reposition the bite in a lot of the times. But for this first case type, we're going to talk about just full mouth recon, no repositioning. You got enough beautiful room. The guy's not symptomatic TMD. Everything's just, he's got a bunch of decay and you just need to restore him. Pretty easy case. You got to design it. You got to do it. You got to learn those techniques to have a really beautiful outcome. Definitely want to tell my students and anybody watching, always concentrate on ideal aesthetics, profiles, the lengths of the teeth. Use a really appropriate lab for that kind of work, and it will make you that much better. The case type 2 that I like to talk about in categories are the full mouth reconstructions that involve vertical dimension opening. So back to case type 1, those full mouths are crowns. I mean, it's just generally crowns. But if you have some missing teeth in there, you can do implants at the same time. All right, so let's call that type 1. Full mouth recon, not opening the bite. You may have, it's mostly all crowns. You may have an implant variation throughout the mouth. How do you do that at the same time? We teach that here at the school, where you're designing, you're preparing, you're holding, and you're seating. So the case can be done at the same shot, doing the implants, doing the crown work, and life is good. The second case type was going back to is the ones that you're dealing with vertical dimension. You have a patient comes in, he needs crown work, and he has maybe some missing teeth as well. So you're going to do some implant bridge work, or you're going to do singles, or maybe you even do partials without implants. So generally speaking, you look at this kind of case and you're like, wow, the guy's overclosed. What do I do? The reason why I like to mention this type case too is because I see in my career a lot of people not knowing how to reposition. Patient's got plenty of bone, good teeth, it's just overclosed, and at that point they're a little frustrated because they don't know how to correct that. So they go in and make a case easy by pulling the teeth. See that time and time again. So I really, really want to tell all the doctors there, learn repositioning to create ideal aesthetics and ideal profiles and jaw positions, so you can learn how to do those type 2 cases. Those are great cases. If you can give your patients that alternative, what I've noticed for those kind of cases that walk through the door is they probably have gone at that point to, I actually had one yesterday. He went to 3-4 other doctors. They all wanted to pull his teeth. The guy had great bone. He was overclosed, but if we repositioned him, we had enough room to make the crowns beautiful. We had enough space to do the implants. Pretty much a straightforward case. So what made that type case 2 a little more challenging is the repositioning. So learn the technique. Go to one of the top schools. We like Occlusion Connections, but people can make their own decisions regarding that. Okay. Things that you got to look for in case type 2s are symptomatic TMD patients. Some of the techniques out there don't address those matters. And I guess in my revision experience, there's nothing like doing a full mouth recon, repositioning the patient, and the patient having a symptomatic problem and ending up in more discomfort. So you guys really need to watch out for those, because that can really bite you in the ass. So I think that's pretty much what I have to say about case type 2s. Now, from here on out in this video, we're going to talk about the other full mouth procedures that I like to separate in 3 categories. So case type 3, these are cases, the rest of these things that we're going to talk about are when you're losing all your teeth, okay? So case type 3s are in full mouth dentistry is denture category, all right? So general dentists, they bring patients losing their teeth all the way up to just what? Regular dentures. So as implant doctors, we have our overdenture category. So overdenture category is you can do those on minimal bone loss. Like if you've got good bone, you extract some teeth, you've repositioned their bite, possibly. But if you have a lot of bone, you don't have a lot of interocclusal space, so you're probably going to be doing some kind of locator overdenture. All right, 4 or 5 implants, 3 implants. But you have to keep things smaller because you don't have a lot of bone loss, okay? That category also going to have the kind of cases where you have lots of bone loss. So locators may not be more as appropriate from an engineering perspective. So you may want to do some kind of creative bar or something like that. So that's a category that can pertain to both type of patients that don't have bone, patients that do have bone, and you really can actually have a pretty good product when it comes to that. All right. 4th category, bridges. Gotta love them. All right. Bridges are wonderful because they're just like the same bridges that you did 2 or 3 here, did an implant with a bridge. It's just these kind of cases you're doing the entire mouth. Usually requiring 6 to 8 implants. You can do immediately load. Case type 4 bridges are wonderful because if you design it, you can extract the teeth, you can load it, make temporaries on the beautiful implants, keeping the profile, keeping the shapes. And this kind of category is broken down into FP1s, 2s, and 3s. FP1s are the ones where you can use that just like you are now. I don't have a lot of bone loss. Maybe Dr. Chaffin's losing his teeth. Well, I would be in a category for full mouth. Either I'd be a denture patient or you would give me more of a bridge category FP1. So really, let's just kind of make this category really simple. The bridge category, FP1s, 2s, 3s, the only difference is FP2s are for you got some bone loss, all right, maybe mild bone loss. Well, so we'll do some bridges and we'll do some pink porcelain, but the profiles will be nice. It will be a fixed category, so I don't need to have the patient come back once a year to take the thing out, okay? That's a huge difference on bridges. Fixed, not taking them out. They're made out of porcelain. A lot of them will do a framework and stack porcelain. They're absolutely gorgeous. And FP3s are bridge work too, but there's a lot more porcelain, and those are for moderate to encroaching on the severe side. You can, there's a borderline there that's almost like a hybrid, but it's still a fixed prosthetic. And you can do these. I've done gunshot victims where they've blown the side of their jaw off, and I've worked with a Mayo Hospital where we're reconstructing a jaw, and we're doing a FP3 hybrid from here to here, and then we're doing crowns all the way across. So you can get creative in your design and prosthodontics on what the patient presents. But that category type 4 bridges is wonderful because you can get creative with it in a full mouth way. All right. So what's important to know that is those kind of cases usually end up dealing with repositioning. A lot of guys have overclosed patients and they're going to be thinking about bridges, but they don't know how to move the jaw around to create space so they can calculate how much room they've got. Okay. The 5th category that everybody knows about is the all-on-X, all-on-4 hybrid category. Let's just call it the hybrid denture category. This is designed for patients that have no bone, dog shit, tons of it, severe bone loss. So if you're having a patient like that come into your office and you're doing full mouth dentistry with implants, that's when you can go into hybrid category. So the two things that can get into severe bone loss, you can do an FP3, you can do an overdenture with some bars, or you can do a hybrid. Okay, hybrids are designed 17 to 22 millimeters of space, tons of room, not much bone. So when you get into these cases, you may have to do some minimal bone reduction, nothing big, nothing short. And we can talk about later the types of hybrids that are available. Hybrids typically can go on regular implants. You can go on zygomatics, pterygoids, all that, but that's just hybrid dentistry. So what I want you guys to know about these categories is each of them are designed for certain type of situations. And when you start getting into full mouth dentistry, it's not about the implants. It starts becoming 100% about the restorative components, what the patient presents, what the needs, of what they want to function like. Does it fit their lifestyle? And as well as does it fit their budget? I call it the 3 F's in sales. You got to have that patient matching in all F's. Fits their lifestyle, functions the way you want to, and financially is feasible for the pocketbook. All right. Now, one of the excuses I get a lot of the times is, the patient can't afford it. The patient can afford it. Hey, listen, when they're walking through your door and they're in a mess like that, you've got to just reach in their heart and kind of find out what they're emotionally attached to, what makes sense to their, what they want to function like, and start with those kind of things instead of jumping in. Well, I don't do bridges because it's too expensive versus hybrids. Just stay out of that shit. You've got to stay out of that shit and not let that sink in your mind. You are their doctor and you're supposed to be able to find solutions that make sense to these patients. So when it comes to kind of money, let's talk about that too. People think that the overdenture category is like, oh, well, it's just a bunch of overdentures and, you're not making money. And quite frankly, everybody watching this video, a lot of them hate denture patients. All right, when you're doing implants, dude, these are great. Typical denture case, can run into about $13,000 per arch. Man, so full mouth, $26,000. So let's kind of go through that. Typical type 1 cases are $40,000 to $50,000. Pretty good money, long-term results. All right, type 2 cases are about $50,000 to $60,000. Okay, overdentures about $10,000 to $13,000 an arch, depending where you live in the area. Okay, and you have that category for minimal bone loss or a lot of bone loss. Type 4 cases, which are bridges, guys. It's about $35,000 to $40,000 per arch. All right, some areas you can even get it down to about $27,000 to $30,000. That includes everything, so it is a little more expensive than your typical hybrid. Your 5th category is hybrid dentures, and this is the category that I see a lot of guys working in. When you have all these other categories to deal with, they kind of focus the practice on just hybrid. So usually, typically, that fee is about $25,000 to $30,000. I think back in the day, we used to split the 25 up, 5 for the lab, 10 for the surgeon, 10 for restorative. I do see a lot of guys playing with that number, going for the cheaper lab to get this prosthetic. So I want to caution you guys about jumping into that. You're going to definitely pay what you get. The other thing I see that in that category that I want you to be aware of is the making patients into type 5 category. Patient walks in, it's got a ton of bone. They're either a denture or a bridge, and you don't know how to do any of that other stuff. So you typically will reduce the bone in order to create two things I see on this. I see that most doctors don't know how to reposition the bite, creating more space. So because if you reposition the jaw, you create more space. Then you calculate the bone loss, and now you got your interocclusal space to make sure you've got enough for your prosthetic of choice. And what I see a lot of people, they understand these concepts, so they keep the bite the same, they reduce way more bone than they have to, and then they start having problems with the prosthetic long term. So that's point 1. Point 2 is reduction of bone. In order to do that, you've got to reduce bone and force the patient into this category. I want to put a word of warning out there for people that don't understand full mouth. You haven't had a lot of experience in there. That is becoming a very big issue right now, is taking a patient that's overclosed, reducing bone, keeping the bite the same, and then putting them into a hybrid, which is meant for detrimental bone patients. That is a lawsuit waiting to happen. That's also something that I see that can get people into big trouble. I cannot tell you how many cases that I get in the office and throughout the last 18 years that are issues with this section. So guys, the tip of the day was to just kind of give you a category section of how you can kind of break it down in your mind of what full mouth reconstruction doctors that are completely trained, what we look at, what we do. Everybody can learn this stuff. So when you're embracing full mouth dentistry with implants, really look at the whole picture. And guys, quite frankly, denture categories are great. I mean, if you're looking at the financial aspects up, they're fun cases. You do a bunch of implants. Patients always love you for them. The bridges are a little more challenging, but those are fun too. Hybrids, those are great too. And, I've done about 3 or 4 of them this month. So people looking at this video, I'm okay with any of these categories. It's just which category the patient belong to. Do I need to reposition the bite or not? Do I need to design it and work up the case? And basically it flows from there. All right. So anyway, hope you guys had enjoyed that little tip of the day. That's my restorative little overview. Why implants are just implants. It's all about the restorative components before you dive into getting really involved with the implant placements. Implant placements over time, why training just comes. But if you learn the restorative components, it will help you in your placement to properly place, how to place the top of the implants being placed ideally. And that's another last comment I'll say is that just because you can place a screw and bone doesn't mean you're placing in the right position. I see a lot of even just denture patients. They have these positioning of the implants for the overdentures and they're encroaching on the buccal plate, or they're tilted, or one's this way, or they're too close together and the thing won't attach. Just simple stuff that each of us can improve. No one's perfect in their implant placement. I don't care how long you've been placing. Everybody has non-integrated implants, and quite frankly, everybody has failures. But what we try to do is to try to keep our eyes on the tiger, increase our training, improve the quality of care, and enjoy our life. So anyway, guys, have a great day. I got to go play some golf, but we'll talk soon. Come to one of our courses, and that's the kind of stuff we go through. Thanks much. Bye-bye.